Hello. Welcome to this presentation. I am Dr. Carlos Sandoval from Sinai, Chicago. I have no financial disclosures relevant to this talk. In this presentation, I want to go over the use of products in everyday life in a GYN or minimally invasive operating room. Sometimes there is a lot of confusion with the names of the products. So here we go. The Gelpoint Mini, probably the star of the entire line of products. It requires an incision of 1.5 centimeters to 2.5 centimeters. It can be used as a multi-port working and assistant port. It can be used as an extraction site. A pro tip is that once you make the umbilical incision, you can use a 15 millimeters trocar to make a clean incision. Make sure to close the single-site incisions in general with a delayed, absorbable suture and grab the corners well. My preference to close this incisions is 0 PDS and with figure of N interrupted sutures, usually 3 or 4 figure of N. Gelpoint. This device was around before the Mini. Make a 2.5 centimeters to 4 centimeters incision. This device allows for better triangulation. For single site, some experts like Dr. Shibley or Dr. Stepp prefer to utilize a flexible scope. The incisions can be a midline, a transverse, or an omega. There are some DRS already working with robotic SGLS like Dr. Arba in Atlanta. Remember to give good instructions for wound care to prevent an SSI or surgical site infection. Gelpoint Path. This one is for colorectal surgery, so don't ask for the blue one. The Gelpoint V-Path. The newest kid on the block. This one is used for the newer technique of notes or vaginal natural orifice transendoscopic surgery. It comes in 3 sizes. The 7 centimeters is compatible with small surgeries like a bilateral salpingectomy, maybe an ectopic. It requires a small posterior or even anterior colpotomy. The 9.5 and 11 centimeters are intended for hysterectomy, but doctors like Dr. Jean Bachland from Belgium have brought this technique to another level by even doing retroperitoneal dissection. American doctors like Dr. Grover May, Daniel Gomez have been really working hard to popularize this technique in the U.S. Other doctors like Dr. Suyash Naval have also brought this technique to India. DRS in Sri Lanka, Turkey, Mexico have also introduced the technique. And let's not forget Dr. Lobo from Spain. This technique is the least invasive of the minimally invasive gynecology repertoire. In my personal opinion, the learning curve is of minimum 10 cases. This technique has also another off-label indication, which is robotic. DRS like Dr. Guan from Baylor University have pioneered the newer approach. The Gelport. The original indications are for urology and colorectal surgery. In gynecologic surgery, it can be used as part of the learning curve of a surgeon for laparoscopy. It can be used in cases that require palpation, bulky, and heavy masses to access the pedicles that are very posterior and are deep. I have used this technique as an option to not convert to full laparotomy in cases of large masses, stage 4 endometriosis, and pelvic abscesses. The incision should be a mini fanny the size of your glove size. The Alexis laparoscopic system, usually for colorectal surgery. Its use has been described in GYN surgery. This can be used in the midline with either a mini fanny or a midline or a McBurney or a left upper quadrant oblique incision. It's ideal to introduce an NZI retrieval bag. This one's come in either polyurethane or nylon. Sizes vary from 5 millimeters, 10 millimeters, and 12/15 cm. I have used it in cases where there is already a pre-existing McBurney appendectomy incision and the patient has a uterus over 500 grams. Some nurses call it the Tupperware Alexis. The containment bags. This ones have been upgraded with a button. In the past, we had to find a way to put it together. We used to place sutures and/or ties. But no need now. It also comes with a tether, which always reminds me of a lollipop. This one can go transabdominal after placement of the Alexis, either Gelpoint Mini or Gelpoint. Some surgeons prefer to place it transvaginally, and some surgeons soak it in betadine before insertion. The 14 centimeters bag has a capacity of 3,400 cubic centimeters, and a 17 centimeters bag has a capacity of 6,500 cubic centimeters. Some surgeons are using it for a cross-bag technique for large dermoid cysts to avoid spillage of the dermoid components in the pelvis due to the theoretical risk of peritonitis. Its use can also be associated for bulky fibroids that once bagged are brought up to the uncapped gel point. At this point, you can sink the containment bag a little bit and place a medium Alexis inside the bag to hold the bag in place and make the space slightly bigger. Then, you have options with your 11-blade. Excite technique from DRS Advincula and Truong, or the shark tooth technique, or the cinnamon roll technique described by Dr. Lee. Be prepared with 3 or 4 blades because they go dull quick. Always inspect that the bag is intact, and I personally always keep the gas on to prevent injury to any organ. Pro tip, ask for Leahy clamps for better traction. Last but not least, a bonus, the Epix Grasper. It's atraumatic, it has endless rotation, and it's easy to do with a single finger. It has a lock for prolonged retraction, assistant fatigue, or even better, to do the spaghetti maneuver. Which is your favorite spaghetti? Well, that is it for now. I hope that this presentation was useful and entertaining. Till next time.